Good evening, all. Today, it is our 5th episode of Diabetes Crossroads, the monthly diabetes update program by RSSDI Kerala State Chapter. We have almost covered all basics aspects of diabetes for physicians. Now we are entering into the complication side. First, one of the microvascular complications, the most common microvascular complications that we are dealing with now, means one of the most common. And we have two eminent nephrologists, two lady nephrologists, Dr. Jayamina and Dr. Jyotipriya. And we have two eminent physician diabetologists to chair this session, Dr. Jayakrishnan and Dr. Radhakrishnan. And Dr. Prashant Shankar is there, who is actually coordinating this entire meeting on Zoom meeting, and he'll be handling. I'll hand over after welcoming you all. I'm welcoming you all those speakers and participants to this special meeting. And I think I'll hand over to Dr. Prashant Shankar for, I think, probably proceeding with this thing. Because our chairperson, Dr. Chandri Madam, is not here, and also our vice chairman also is not here. Because of that, I think probably we don't have to wait for them. I think we have permission for that. Now I think I ask Prashant Shankar to proceed. Please take over, Prashant.
Thank you, sir. Thank you. Welcome everyone to this 5th episode of Diabetes Crossroads, which has been running in a very good way over the last 4 or 5 months. As you know, it is a monthly educational update on diabetes, which is brought by RSSDI Kerala chapter. As Dr. Suresh said, Dr. Chandini, our chairperson, and Dr. Jyotidev, our vice chairperson, are busy with the national meeting, which is going on concurrently, and they will be joining as the national Zoom meeting ends. So without wasting much of time, we will go into today's topic. Today we are discussing one of the most important microvascular complications of diabetes, that is diabetic kidney disease. And for that, we have two eminent nephrologists. The first person is Dr. Jayamina from Calicut, and the second person is Dr. Jyotipriya from Pathanamthitta. And we will be discussing it in two topics. The first will be on the basics of CKD in diabetes. Second will be a discussion, case-based discussion on diabetes, because what we thought was that if you're going with back-to-back lectures, it might seem monotonous. And what we intend to give the audience from this meeting is the practical application. So that more patients with diabetes are treated as per the guidelines, and we make sure that patients who are having the complications of diabetes are managed in a better way, get proper referrals, early treatment, early screening for complications. So that is the basic purpose of these meetings like this. So we have two eminent physicians and physician diabetologists as chairpersons. I would like to invite Dr. Jayakrishnan B, who is a physician from Tirur. He works at Safe Care Clinics, Tirur, Malappuram. And we also have Dr. Radhakrishnan, who is a senior physician from Palakkad, who works as a physician and diabetologist at Palakkad Medical Center. So I would like to hand over the session to the chairpersons, and I request them to take over the proceedings. As they introduce the speakers, I will be putting on the speaker slides.
And thank you, Dr. Suresh sir and Dr. Prashant, for the nice start. And welcome Dr. Jayamina Madam and other Jay Madam and all of you once again for this excellent academic initiative by RSSDI Kerala chapter. And let me introduce Dr. Jayamina P. Madam is the senior consultant nephrologist at Baby Memorial Hospital and Diabetic India, Calicut. Madam has done MBBS from Medical College Kozhikode, MD General Medicine from Stanley Medical College Chennai, DM Nephrology from Kottayam Medical College, and she has worked at Kottayam and Alappuzha Medical Colleges, and from 2012 to 16. Madam was the consultant nephrologist at PVS Hospital Kozhikode, and Madam was also an assistant professor in Department of Medicine and Division of Nephrology, Malabar Medical College, Calicut till 2018. And she had publications and presentations in conferences and journals, including BMJ, a lot of Scopus and Google Scholar journals, and Madam was the principal investigator for Credence and Amgen trials. And all of us are eagerly waiting for your talk, ma'am. Please take over.
Good evening to all. First of all, I would like to thank everyone for giving me this opportunity. I will start with the slides. So today's talk would be about the guidelines for managing diabetic kidney disease for physicians. So what is the need for addressing this issue? From various studies, we have actually got the data like 1 in 10 adults worldwide are suffering from CKD in one form or another. Nearly 500 million people are actually suffering from CKD worldwide. And the approximate prevalence in India is about 800 per million population. And among that, almost 150 to 200 million are in ESRD. And India has got the maximum number of CKD cases among men, especially the age group of 51 to 60. Okay. And this number is going to increase further with the projected increase in diabetes. So the problem of ESRD is about 100 per million per year. And ESRD is about 800 per million and prevalence. And hypertension diabetes constitutes to 63% and only just 10% gets access to renal replacement therapy. So that is the state of India where we are marching towards ESRD, but we don't have the facility to give them. So what happens? Here you can see diabetic nephropathy actually constitutes to 41% of the etiology of CKD and hypertension to 22%. The rest are of fewer number, in fact. So among the top 10 countries with diabetes, China, India, and Pakistan are top on the list. And you can just see the number of people with diabetes in India. It's about 74 million as in 2021. And the projected is almost going to be double by 2045. So with that, we know what would be the increase in the burden of CKD we are going to see in the future. So what is the natural history of diabetic nephropathy? This is being typically described only in type 1 diabetes, because only in type 1 diabetes we know when actually it starts. Diabetes starts. There are basically 3 stages: the pre-stage, there's the incipient stage, and there's the overt stage. In the first stage, you actually get increase in GFR with intermittent microalbuminuria with exercise. Here you can actually see the renal hypertrophy going on. The incipient stage, you get the microalbuminuria with hypertension, and structurally you can see the mesangial expansion, GBM thickening, arterial hyalinosis. But in the overt stage, where you have macroalbuminuria with, or even nephrotic syndrome with progressive decline in GFR. Here you can see the structural changes like mesangial nodules and tubulointerstitial fibrosis. Beyond this stage, it is irreparable. So this is the normal glomerulus. You can actually make out the thin hairline glomerular basement membrane. And you can actually see very, very thin mesangial spaces. Here you can see the expanded mesangial spaces, almost forming nodules, the thick-walled glomerular capillaries. And this is the overt stage where you can see the Clemenston-Wilson nodules, where it is a acellular expansion of the mesangium with dilated peripheral capillary loops. And finally, this whole glomerulus becomes sclerosed. This is how it goes. So microalbuminuria is the earliest detectable manifestations which we know. And its prevalence is about 25% after 10 years of diabetes. And the annual progression is about 3% normally. But it is not so always. There are so many promoters of diabetic nephropathy. As we know, like the common things that promote other hypertension. These are the remediable things which we can actually correct. Control of hypertension. Next is the glycemic control, smoking, and dietary protein intake. Although various other things which are not under our control because of AC gene polymorphism, oligonephropathy, RAS inhibition, Sometimes they might not benefit from RAS. All these things are not in our hands, but all these 3 or 4 things are definitely in our hands. So can we develop diabetic kidney disease without microalbuminuria? Yes, about 36% of type 2 diabetic people, diabetics have GFR of less than 60, have normal albuminuria, normal albumin excretion rate. And this was seen in a population-based study of 7.9 people with T2DM and a GFR of less than 60. In type 1 diabetics, almost 24% of people had a normal albumin excretion but a decreased GFR. So there is an entity where you can have diabetic kidney disease without albuminuria. So diabetic kidney disease without albuminuria, where is it, whom do you actually see it? It is seen in older population, higher in women, seen more in hypertensive individuals with dyslipidemia or other macrovascular complications, cerebrovascular disease, and the smoker numbers are few in this. So how to screen? So all patients with type 2 diabetes should be screened for diabetic nephropathy at the onset, because we don't know when actually it started for them. So initially it should be screened at diagnosis and annually thereafter. And what should you look for? It is actually the albumin excretion rate in a random spot sample, and there can be fluctuations in urine albumin excretion. So you should at least take 2 to 3 samples collected within 3 to 6 months. There are various causes of albuminuria, transient, like fever, exercise, high salt diet, hyperglycemia, hematuria, dehydration, congestive cardiac failure, and high blood pressures. So you should always screen 2 or 3 samples before labeling the patient as a microalbuminuric. So these are the definitions for albumin excretion. Normal in spot is less than 30. Microalbuminuria is 30 to 299 milligram per gram, and macro is more than 300 milligram per gram. So serum creatinine should be initially checked at the diagnosis and annually in all patients. And GFR estimation is done from creatinine, and with which we actually stage the CKD. So by the KDIGO definition for the GFR, you have stage 1 more than 90 and mild CKD 60 to 89. This can be 3A and 3B, 45 to 59, 30 to 44. And these 2 are the severe stages. Stage 4, which you have GFR of less than 20, less than 29, and CKD stage 5 of less than 15. And stage 1 and 2, although the GFR might be more than 60, the presence of kidney damage can be noted by the presence of urine analysis, imaging, or renal biopsy. So definition of microalbuminuria is optimal is less than 30, high is 30 to 299, and very high is more than 300. So with GFR and albuminuria, they have actually staged CKD with G1 for G for GFR and A for albuminuria range. Here you can see it is a G1, A1. The patient's having a GFR of more than 90 with literally normal albuminuric range. So these green forms mild. This yellow forms, this is almost normal. This is mild. This is moderate risk. Orange forms moderate risk. And this red columns forms the high risk patients. Okay. So what is a comprehensive diabetes and CKD management? It basically includes a lifestyle, first-line drug therapy, and goal-directed therapy. The lifestyle, we all know, it's basically the diet, exercise, smoking, and smoking cessation and weight reduction. We'll go one by one. So in the drug therapy, we can actually offer to most patients, but not to all. But lifestyle modification should be applied to everyone. So SGLT2 inhibitors are being recommended in diabetics with CKD, and RAS inhibition should be recommended for all with albuminuria and hypertension. So lifestyle modification includes encouraging smoking cessation, weight loss, maintaining normal BMI, increased physical activity of more than 30 minutes per day for most of the days, and dietary changes. Smoking cessation should always be stressed because it it actually influences the onset and the progression of DKD. It causes accumulation of reactive oxygen species, and smoking cessation reduces cardiovascular risk. So whatever ways like counseling or some anti-smoking medications, whatever be the thing, we have to use it, and we have to actually stop smoking. Then the dietary changes, what we can actually do in CKD is the low protein diet. In early stages, it can be reduced to 0.8 to 1, and late stages, it can be reduced to 0.8, because increase in protein actually increases the load to the kidneys and accelerates the decline in GFR. So the dietary changes, are basically the salt intake, which to be limited to 6 grams of sodium chloride per day, and alcohol intake. So these are the lifestyle interventions. Let's see the first line drug therapy. The first line drug therapy includes, these are the latest recommendation, which says that SGLT2 should be initiated to anyone more than 20. I basically introduce it only if the GFR is more than 30. More than 20 would be a bit more risky. And it should be continued till dialysis or transplant. That's what they recommend, but a bit difficult in continuing up to dialysis. Next is metformin, should be given till GFR is till 30. And the next is targeted therapy. They recommend GLP-1 receptor agonist to achieve individualized glycemic target, or if there's persistent albuminuria. Okay, the other drugs to be added down the lane to achieve the glycemic target. Whereas for the hypertension control, RAS inhibition is the first, followed by, if urine ACR is high, add non-steroidal mineralocorticoid receptor agonist. If the BP is high, blood pressure is high, try for a dihydropyridine calcium channel blocker or a diuretic. And if needed, a steroidal mineralocorticoid receptor agonist. And moderate intensity to high intensity statin, depending on the underlying atherosclerotic risk. So what can we actually achieve through glycemic control? Preserving kidney function? Yes, many of the studies have actually pointed that glycemic control, with adequate glycemic control, we can achieve a preservation of kidney function. But is it all sufficient to just a glycemic control? Glycemic control has been beneficial effect on the kidney by decreasing the albuminuria in type 1 and 2 patients. But its role is more only as a primary prevention, and specially used in early stages of diabetes, early stages of microvascular disease. But it has got lesser role as a secondary intervention after complications, especially macrovascular complications has set in. See, you can see this is the sclerotic glomeruli. After pancreas transplantation, you can see the histological changes, and you can see this is almost resolved. And this is what happens after achieving euglycemia. But always remember, there's a U-shaped relation between HbA1c and mortality in patients who have already established complications of macrovascular diseases. So what we had seen is that hypoglycemia and mortality both increases in type 2 diabetes patients with intensive control. And although there is 21% reduction in nephropathy, there's no reduction in cardiovascular disease. And so the glycemic goal should be tailored, basically because the consequences of hypoglycemia are very severe: myocardial infarction, seizures, stroke, death, etc. So it should be set high for frail and elderly people, and with patients with erratic eating habits, patients with an established late stage of CKD, or patients with longer duration of diabetes, macro and microvascular complications, and patients with decreased awareness of hypoglycemia. So is HbA1c reliable in CKD? We all have that doubt. Basically because the HbA1c is being influenced by the uremic solutes and the metabolic acidosis. And anemia is a big problem in CKD, who might require recurrent transfusions, erythropoietin stimulating agents, iron supplements, etc. But this is what is happening. CKD stage 1 to 3B, the reliability of HbA1c is high. And it is also advised like twice per year if patient is stable, or 4 times per year if the patient is not achieving target. But CKD 4 and 5, the reliability seems to be low. So basically the factors deciding on individual HbA1c target, it can range from less than 6.5 to 8, less than 8, depending on the severity of CKD. CKD 5, it is 8. Macrovascular complications present and severe, high target for a higher HbA1c. Comorbidities are many, again. And life expectancy is short, then don't target for a lower HbA1c. And basically resources of hypoglycemia management, the patient is staying alone, better don't target for a lower HbA1c. And the propensity to cause treatment is high, propensity of treatment to cause hypoglycemia is high, better target for a higher HbA1c. And longer the duration, disease duration, better target for higher HbA1c. And most important is the life expectancy and patient's attitude towards our treatment. So basically, the target should be between 6.5 to less than 8. So this is what ADA advises. It's basically less than 130 is the fasting and less than 180 is the postprandial. So the treatment should be tailored to individual requirements. The choice of anti-diabetic should be depending on the adverse effect, risk of hypoglycemia, tolerability, ease to use it, long-term compliance, cost, and non-glycemic effects like weight, blood pressure, lipid profile. With that, we have this diagram. If the patient is having heart failure, SGLT2 or GLP-1 receptor agonist will be more useful, and thiazolidines wouldn't be. If the patient wants to avoid hypoglycemia, these are the drugs which are more helpful than long-acting insulin or sulfonylureas. And patient wants to avoid injection, DPP-4 or sulfonylurea or GLP-1 receptor agonist, oral GLP-1 receptor agonist will be more useful. Okay, this will be a guide for selection of the glucose lowering drug. And the rate limiting factor for achieving optimal glycemic control is basically, in CKD is basically like there's decrease in clearance of insulin by kidneys, and medications used for treating diabetes are basically excreted through kidneys, and there is impaired gluconeogenesis because of decreased kidney mass and malnutrition. All these patients have a malnutrition, inflammation, atherosclerosis, and acidosis limit hepatogluconeogenesis. All these causes hypoglycemia and CKD. So be a little more cautious in treating them. So these are the drugs with almost these drugs which are given in red are causing more of hypoglycemia than the drugs given in green. So with glucose lowering therapies in patients with T2DM and CKD, basically metformin, things which are basically changed are you can continue metformin till GFR is almost up to 30. And discontinue if it is below 30 or patient is on dialysis. And SGLT2, I would say it is better to use it till GFR is up to 30. So what are the things? We all know that SGLT2 is the new molecule and it's very useful in reducing the weight and decreasing the, it's very helpful in the presence of cardiac failure. But one has to be really cautious in using this drug. Basically because it has got its own side effects. It causes volume depletion, it causes hypoglycemia and diabetic ketoacidosis. So if the patient is having proteinuria and heart failure, this drug should be in priority list. But always look for foot ulcers, look for the chances of developing ketoacidosis, see whether the patient is immunosuppressed. In immunosuppression, the risk of genital infection is really high and recurrent UTI is also high. And in states of volume depletion, especially concurrent diuretic use, the incidence of AK also increases. So there's a sick day protocol in using SGLT2. If there is any illness, temporarily hold SGLT2, keep the patient well hydrated, check glucose and check blood ketone levels. Any procedure, if the risk of decay is high, hold SGLT2 on daycare procedure, especially if the patient is fasting. If it is a procedure where you actually expect fasting and bowel preparation, just hold it 2 days prior itself and check blood sugar and blood ketone levels on admission. Restart SGLT2 only after patient starts eating and drinking normally. So SGLT2 is such a drug which can cause severe dehydration and ketosis. So these are the doses which are normally used in CKD. The next drug which we think is very important is metformin. And although it's exclusively eliminated by kidneys and it's got a half-life which can increase with decrease in GFR, the overall incidence of lactic acidosis is very less. So now the recommendation is that it can be used up to a GFR of 30. And even GFR of 45 to 59, you can actually give the same dose without much dose reduction. Only in certain conditions when you actually expect there is a chance of acidosis, you can temporarily decrease dose or hold the drug for the time being. But don't forget to don't forget to check the vitamin B12 levels at least annually in patients who are on metformin for more than 4 years. And decrease the dose to half if GFR is between 30 to 44. These are the conditions where holding metformin would be of real help. If the patient isn't having any active infection or patients having any acute myocardial infarction, or you're going to actually have a planned coronary angiogram or using other nephrotoxic agents. So GLP-1 receptor agonist is the next drug of choice, but we have our own problems in using these drugs because it delays gastric emptying. Most of the CKD patients have delayed gastric emptying. They have decreased appetite, and even this drug actually contributes to satiety. So using this drug has been a bit difficult in CKD patients, although this is the second line of drug which is being recommended. So to minimize GI side effects, start this drug at a lower dose and then up titrate. And remember, it should never be used in combination with DPP-4. And although the risk of hypoglycemia is less with this, but in combination, it also adds to hypoglycemia. And these are the doses doses recommended in CKD. Liraglutide has no dose adjustment, and this liraglutide also has got no dose adjustment. Sulfonylureas, basically, if the GFR is less than 60, glibenclamide would be difficult to use. Basically, it has got active metabolites which are being cleared by kidney. Even glimepiride has also got active metabolites. Ideally, avoid glimepiride if the GFR is below 30. But glipizide is about less than 10% cleared renally, but can be used in caution with GFR less than 30. So other drugs like glycoside also metabolizes several inactive metabolites. So it can be used till a lower GFR. Thiazolidinones actually has got lower risk for causing hypoglycemia, so it can be used safely. But the problem is fluid retention in CKD. Glinides, which are shorter half-life and shorter duration of insulin release, but even then it can also cause hypoglycemia. Avoid nataglinide because active metabolite of nataglinide accumulates in CKD. Ripaglinide is safe and it can be used below GFR of 30. Alpha-glucosidase inhibitors, basically acarbose, it's minimally absorbed from the GI tract, less than 10% of the drug, and active metabolites are present in urine. So it can be used, but miglitol should be avoided because there undergoes a systemic absorption and 95% renal clearance. Oglibose has got minimally absorbed and negligible liver metabolism, but there's no data in advanced CKD. DPP-4, sitagliptin is 80% cleared by kidney. So dosage adjustment should be made according to the GFR. Linagliptide is negligible amount is being cleared renally, so no dosage adjustment is required for linagliptide. And insulins, basically 30 to 80% of insulin is being cleared by kidney, And in CKD, you expect a prolonged insulin half-life. And there are two types, type, dose, and administration should be tailored to each patient. So we actually prefer a rapid-acting insulin to match each meal, and a basal bolus regimen is what we actually prefer for CKD. We use more of regular insulin, which has got an onset very fast, and peak is 2 to 3 hours, and lower cost compared to rapidly acting analogs. So intermediate insulin has its own, the earlier stages of CKD, you can definitely use these intermediate acting insulin. Longer insulin analogs for basal, glargine, and detrimer are the usual things which we prefer, but due to the high cost, this has been a problem. Premix insulin we actually use in earlier stages of CKD. So basically reduce the dose of insulin to 75% if the GFR is 10 to 50, and to 50% if GFR is less than 10. And use, if possible, use analogs. If not, use short-acting agents. So what is the need of blood pressure control? Basically, the high blood pressure is one of the causes for accelerated progression of CKD. So diabetes increases the risk of cardiovascular diseases potentiated by the level of systolic blood pressure, and the incidence of progressive microalbuminuria is also associated with blood pressure. So progression of retinopathy is also associated with high blood BP. So KDIGO guideline is basically you have to have an office recording with so many requirements. I think all these requirements are practically a bit difficult, though we can try out. And the recommendation is basically less than 120/80 office BP recording as per standardized office BP measurement. But it's very difficult. So hand in hand, you can actually have a home BP monitoring. This is what we do. Ask the patient to monitor his blood pressure at home, which should be completely normal at times than the office blood pressure. And high blood pressure in CKD should be targeted to a blood pressure of less than 120, which requires multiple number of drugs and multiple office visits. And so in older people, targeting to a BP of less than 120 will be very difficult. So we have to balance the risk and the benefits. And the benefits of intensive BP lowering are less among certain people with concomitant CKD and diabetes. So the BP targets, just like diabetes, should be individualized. And AC inhibitors are the drugs of choice for CKD and diabetes. So what should you do after initiating ACARB? Basically, after 2 or 4 weeks, monitor serum creatinine and potassium within 2 to 4 weeks after starting or changing the dose. If it is normokalemia, less than 30% increase in creatinine, increase the ACARB to the maximally tolerated dose. If there is hyperkalemia, look for concomitant drugs. If there is 30% increase in creatinine, review for other causes of AKI like volume depletion, medications, diuretics, NSAIDs, renal artery stenosis. So in hyperkalemia or increase in creatinine, reduce the dose or stop ARB accordingly. So initial dose should be 15 to 25% of the maximal dose. Check for diet, check for acidosis, hypoglycemia, oliguria, etc. Whenever you find the patient is having hyperkalemia, and look for other medications, NSAIDs, beta blockers. Reassess whether you can actually increase the dose or we should decrease it, and recheck within 5 to 7 days. If it does not return to baseline, discontinue or add a loop diuretic along with ARB. So what are the adverse effects? Basically, it can cause hypotension, it can cause GFR decline and hyperkalemia. So look for correctable causes. So when you should check for all these things? It depends on the baseline GFR. It depends on the baseline systolic blood pressure. If the patient has got a decreased blood pressure, you should check within 2 weeks. If the patient has got a normal blood pressure, it can be within 4 to 12 weeks. Okay. So the problem in starting AC and ARB in people with renal artery stenosis. Basically, ARB and AC actually dilates the constricted efferent arteriole. But in people with renal artery stenosis, the blood flow to the afferent arteriole itself is very much decreased. So the GFR is basically maintained by the constriction of efferent arteriole. Once you open this up, the GFR decreases suddenly in patients with renal artery stenosis. But in diabetics, because of the increased intraglomerular pressure, the dilatation of efferent arteriole actually decreases the glomerular hypertension, and it decreases the proteinuria. So you have to actually weigh the balance between proteinuria and decline in GFR. So combination therapy is now out of question. You can't combine ARB and ACE together. And one more thing to say is that aldosterone escape occurs in 40% of patients who are on ACE and ARB. And ideally, now the recommendation is for non-steroidal mineralocorticoid receptor agonist because it has got lesser incidence of hyperkalemia, acute kidney injury, and other side effects like gynecomastia. So it's more selective for mineralocorticoid receptors and similar reductions in albuminuria and lower risk of hyperkalemia. So you can see higher the number, less is the affinity for the receptor. So mineralocorticoid receptor, Finrenone is actually 18 and has got high selectivity for it. Whereas the other numbers are very high, it hardly acts on the glucocorticoid, androgen or progesterone receptors. And these are the trials which actually showed, these are very large trials which actually showed beneficial effect on the kidney and on the heart. So this Fidelude trial actually is for the kidney, and it showed the mean GFR of 44 at enrollment and ACR of 850. And Figaro trial, you can actually see the changes in the GFR and ACR. So basically, it should be given to people who don't achieve blood pressure control or they have persistent albuminuria. Of course, potassium should be monitored even more closely. Management of lipid and CKD. One good thing of lipid and CKD is that in CKD, we don't treat to target because there are so many players for coronary artery disease or cardiovascular disease in CKD apart from lipids. So it is just like any newly identified CKD, lipid profile should be checked. And if the patient is more than 50 years with a GFR of less than 60, patient should be started on statin. If the patient is more than 60 with a GFR of less than 60, in CKD stage 1, more than 60 ml GFR, CKD 1 or 2, treatment with statin is recommended. But in people with less than 50 years and CKD, statin is indicated when patient is having CAD, diabetes, ischemic stroke, or a 10-year estimated coronary artery disease of more than 10%. And in patients who are on dialysis, statin or estimab was not recommended, but already receiving can continue. So these are the recommendations for diabetes and CKD with high-risk coronary artery disease. Basically, I want to show you this graph because you can see the hazard ratio along with LDL with a GFR as one of the variables. In earlier CKDs, earlier stages like GFR of 90, the hazard ratio actually increases with increase in LDL cholesterol. But this doesn't happen as the CKD stages goes down and down. Here you can see the GFR is just 15, but the hazard ratio doesn't go up with increase in LDL cholesterol. This basically, it doesn't mean that the cardiovascular disease rate is less in end stage. It is basically, there are many other factors that actually play a role in development of coronary artery disease, basically acidosis, uremic metabolites, and coronary artery calcification, PTH, phosphorus. So there are various other players apart from LDL cholesterol alone in CKD, which causes coronary artery disease. So these are the recommended doses of statin. And this is totally different in comparison to that of coronary artery disease with CKD. So basically the management of CKD and diabetes If when GFR is more than 60, yearly check urine albumin excretion, check creatinine, check potassium, and treat accordingly. If it is 45 to 60, you have, apart from the rest, you have to again monitor the electrolytes, bicarbonate, hemoglobin, calcium, phosphorus, and PTH yearly. Ensure adequate vitamin D sufficiency and referral for dietary counseling. If it is 30 to 44, GFR every 3 months. Monitor all these things and consider need for dose adjustments of medications. So what are the diagnostic dilemmas? If you see a patient in the absence of diabetic retinopathy with proteinuria, if there's a rapid decline in GFR, or if there is an increase in proteinuria or nephrotic syndrome right from the presentation of nephropathy, if there is an active urinary sediment, especially RBCs, or if there is a decline in GFR of more than 30% within 2 to 3 months of initiating ARB. So all these things actually point towards you're not dealing with diabetic nephropathy, you're dealing with some other renal issue. So you can, when to actually refer to a nephrologist? When GFR is less than 30. Yes, when patient is in CKD stage 4, basically to counsel him for a renal replacement therapy. Or just like mentioned, is there a possibility of non-diabetic kidney disease? Duration, if a CKD onset in type 1 diabetes with less than 10 years of duration, heavy proteinuria at presentation, abnormal findings in renal ultrasound, resistant hypertension, rapid fall in GFR, or active urinary sediments. Thank you. Thank you for your patient listening.
Thank you, madam. And over to Radhakrishnan, sir.
Dr. Radhakrishnan, you are muted.
Please unmute, sir. Radhakrishnan, sir, please unmute.
Yeah, I'm audible now?
Yes, sir.
Yeah.
Good evening, one and all. And first of all, let me thank Dr. Jayakrishnan and the RSSDI team for asking me to chair this wonderful session on diabetes and kidney disease. Now we have Dr. Jayamena talked very excellent about, gave an excellent overview about the from histopathology to the management of diabetes kidney, with the oral anti-diabetic and hypertension, everything. Now next, Dr. Jyoti Priya will be talking on, the next speaker, the eminent speaker will be talking on different case scenarios, where we how to handle, if you get a case, how do we manage? And she'll be talking on different cases. So about Dr. Jyoti Priya, she completed MBBS from Amrita Institute, and MD from Government Medical College, Tiruchirappalli, and DM from MMC, Chennai. And she's the right person to talk on this topic because she had an excellent exposure in the field of diabetology from different centers, and also is consultant physician in the Indian Institute of Diabetes at Trivandrum, and presented research papers in various conferences like World Congress of Nephrology, and prize-winning presentation in various regional and national conferences in nephrology. And her areas of interest are chronic CKD, renal transplant, and glomerular disease. And without wasting much time, over to you, Dr. Jyoti Priya.
Thank you, sir, for that kind introduction. And I think by now, after Madam's elaborate, extensive introduction to the topic, we are all familiar with the management of diabetic kidney disease. So with that, I will be dealing with 2 case scenarios, and in practical aspects, what all dilemmas we face while dealing that patient in our day-to-day OP. So moving on to the first case, we have Mr. A, a 58-year-old gentleman, a chronic smoker, a diabetic of 8 years duration, hypertensive of 3 years duration, and dyslipidemic. He presented with a blood pressure of 160/100 with pedal edema, BMI of 31.5, and fundus showing diabetic retinopathy changes. Now, investigation showed uncontrolled blood sugar of postprandial of 280 and HbA1c of 9.4 with serum creatinine of 1.2 milligram per deciliter. So when we calculate into eGFR using CKD EPI formula, it will come roughly around 66.6 ml. and potassium of 4.5 and dyslipidemia present. Now, his urine analysis revealed urine albumin present with urine albumin creatinine ratio of 1,326 milligram per gram. So he's having very severe proteinuria. And currently, he is on tab glimepiride, metformin, cilindipine, and telmisartan 40 mg only. Now, what are the main issues we are having in this patient? He is having uncontrolled glycemic status, uncontrolled blood pressure level, severely increased albuminuria. This is previously it's known as macroalbuminuria. Now the terminologies are slightly changed. So microalbuminuria has been replaced with moderately increased albuminuria and macroalbuminuria with severely increased albuminuria. The same cutoff level only, more than 300 milligram per gram is severely increased albuminuria. And there is mild renal dysfunction, dyslipidemia, he is obese, and he is a smoker. Now we have to deal this patient with these issues. Now, as we all know, the risk factors for progression of diabetic kidney disease. So in our patient, it's a relatively longer duration of diabetes, and he's having uncontrolled glycemic status, hypertension, dyslipidemia, obesity, smoking. So all these factors pointing to a favorable atmosphere for progression of the diabetic kidney disease. Now, what can we do? So in the first place, we have to optimize the glycemic status. So in this patient, we actually advised insulin administration, but patient was reluctant. So we escalated the dose of sulfonylurea. We added gliptins. And for control of blood pressure, we increased the dose of ARBs. And statin was added as per the guidelines from CKD stage 1 to stage 5. We can start statin except when the patient is on dialysis. And one thing regarding statins, we can go for a normal dose, but as the renal failure advances, always try to avoid higher doses of statins. And regarding the antiproteinuric measure, we started the patient, we increased the dose of telmisartan and always try to give maximum tolerated dose of RAS inhibitors. What we generally do is we start the patient on RAS inhibitors, but we have a tendency to halt with the initial dose itself. So we can titrate it till the maximum dose the patient can tolerate. And next step we did was we added an SGLT2 inhibitor. Now this was detailed explanation was given on this by a previous speaker. So when we start SGLT2 inhibitors, we have to follow the sick day protocol, have to withhold in case of surgery or critical illness. So the advices we have to give, one is if the patient has any fever, a need for hospitalization, loose stools, vomiting, where his volume status can be compromised, in such situation, he needs to withhold this drug till the disease is over. So caution on volume status, we have to have that caution, and foot care. So ideally, in case of foot ulcers or a severe peripheral vascular disease, it's better to rethink in starting SGLT2 inhibitors because they're already in a precarious limb with the compromised blood supply. Further adding of SGLT2 inhibitors can increase the risk of further compromisation of the blood circulation. So in case of foot ulcers or severe peripheral vascular disease, think once again before starting SGLT2 inhibitors. And another thing, it has a diuretic action. So basically, before starting SGLT2 inhibitors, assess the volume status of the patient. And if the patient is already on a diuretic, in our case, the patient is not on diuretic, so I could easily start. But otherwise, if the patient is already on a diuretic, make sure the volume status is ensured, and sometimes we have to reduce the dose of diuretics and then introduce SGLT2 inhibitors. And apart from that proteinuria reduction benefit and the blood sugar lowering effect, there is a benefit of reduction of blood pressure and even weight loss with SGLT2 inhibitors. And this was explained already. Now, one thing I want to emphasize is when we start SGLT2 inhibitors, there can be a small acute drop in eGFR. So basically, it's always better to warn the patient that the creatinine, there is slight increase is possible up to 20 to 30%. We need not stop the drug even if that increase in creatinine is seen. And usually in another 2 to 3 months, this drop in eGFR will be compensated. It will be coming back to normal. So we advised dietary modification. Patient has to be put on a moderate potassium diet because our aim is to control the proteinuria and we want to give maximum tolerated dose of RAS inhibition. So a potassium moderate diet will be beneficial. And protein in diet, already told, the target that guidelines recommend a target of 0.8 gram per kg per day in case of proteinuria. But one thing we have to think in mind, because of our restriction, patients should not be pushed into malnutrition. Most of our patients or many of our patients, they might not actually taking the enough protein. See, all these recommendations are based on the Western diet where the non-vegetarian diet is a predominant one. So when we are applying that recommendation, into our practice, we have to follow an individualized approach. So if the patient is already having a deficiency in protein, we shouldn't emphasize or push him to malnutrition by advising him to more and more protein restricted diet. It's always better to ask him to cut short the animal proteins, especially the red meat. So in that case, uric acid reduction will also be possible. So protein in diet, the target is 0.8 gram per kilogram per day, but have an individualized approach. And then the rest of the things, he needs to have quit smoking, increase the physical activity. Obesity should be controlled. See, weight reduction is very essential. Obesity per se, forget about diabetes and hypertension. Obesity per se can result in renal dysfunction, obesity-related glomerulopathy. So there is a very important role in increasing the physical activity of the patient. Diabetic retinopathy follow-up, food care, cardiac evaluation, and avoidance of NSAIDs and nephrotoxic drugs. So all these things should be advised to the patient. Now, my patient is coming after 2 weeks. I call for a review to repeat the RFT. Now, the creatinine is 1.4 and potassium is 4.9. So, seeing that mild increase in creatinine, no need to panic, but make sure other causes of AKI are ruled out. So, if the adequate hydration is ensured, if there is no volume loss, if there is no other cause for AKI, we can continue with the current regimen. Now, this regimen is continued for next 6 months. Now, patient is coming with a creatinine of 1.3. So it has reduced from the initial surge. Albumin creatinine ratio of 600 milligram per gram. So still there is residual proteinuria. Potassium of 5.4. Now the question is, seeing this potassium, do we have to immediately reduce the dose of ARBs and or stop it? So as already told, we need not immediately jump into reducing the dose. We can opt for other measures to control the potassium. So dietary modification. So I'd emphasize on the potassium restricted diet. We can add sodium bicarbonate if the patient has metabolic acidosis, and that will again reduce potassium to some extent. Look for any other medications like NSAIDs or herbals, which can increase the potassium. And if the patient is having concomitant volume overload, we can initiate diuretics and go for GI cation exchanges if possible. So after resorting to all these medications, all these resorts, and still potassium is high, then only consider decreasing the dose of ARBs. Now this has already been explained. The main thing, after the initial strategies, if the initial strategies fails, we can go for reduction of the ARBs. Now again, so with that modification, the diet and other measures, the potassium became controlled. After 1 year, he again came for follow-up. Now the potassium is around 4.5. And in the last 3-4 visits, it is almost stable. Urine ACR is 500 milligram per gram. Still, the albuminuria persists. Creatinine is almost stable, 1.32. Now, what next? So, maximum dose of ARBs, SGLT2. Now, what is the next option? So, there comes the role of mineralocorticoid receptor antagonist. That is Finrenol. This is actually a relatively newer drug. This has been introduced. It has US FDA approval was being obtained last year. And in Indian scenario, only recently it has been launched. So unfortunately, I don't have a personal experience in using this drug, but studies from the Fidelio DKD trial and Figaro DKD trial, very good response has been obtained. So there is certain patient selection criteria we need to adopt. One, the eGFR should be more than 25 ml with a normal serum potassium. So in all the trials, the potassium, the target, they kept at a range of 4.8 milliequivalent. And the patient is having residual albuminuria in spite of the maximum tolerated dose of RAS inhibitors as well as SGLT2 inhibitors. So in this condition, if the potassium is in normal limit, we can try Finrenol. So this is what KDIGO guidelines say. So if the potassium is less than 4.8, we can start Finrenol. It is available in 2 doses. So in our country, it is now available in the brand name Kerendia. So here it is, it has 10 mg and 20 mg. So it's a recently launched product. So if the eGFR is less than 60, we can start with 10 mg, then we can up titrate. And if the eGFR is more than 60, start with 20 mg. Now we have to monitor, have a close monitoring of potassium. Now, if the potassium is increasing, if it is more than 5.5, we have to hold the drug and make the adjustments to reduce the hyperkalemia potassium level. And once the potassium comes back to 5, we can restart the drug. So hypothetically, I have introduced this drug into my patient, and after 2 years, and after that, his albumin ratio has come down. It's almost around 250, and it's still on diet modification and other lifestyle modification. Now, after 2 years on follow-up, he's again coming. This time, it's with a sudden onset of bilateral pedal edema of relatively recent onset with a rise in creatinine to 2.1, urine albumin significant elevation, 4+, urine albumin creatinine ratio of around 3 gram, and urine showing 10 to 15 RBC. Now, this is a scenario where you have to, or we have to think about a non-diabetic kidney disease in a diabetic patient, in a diabetic nephropathy patient. So this we have already, Madam has explained, this condition, we have to refer the patient to a nephrologist. So there, apart from diabetic nephropathy, there is something else affecting the kidney. So when you consider the need for a renal biopsy in diabetic kidney disease, when there is a rapid worsening of renal failure, a rapid worsening of proteinuria, a sudden onset of massive proteinuria, then a shorter duration of diabetes, when we are clinically suspecting other glomerular disease, any other serological markers are positive, in these conditions, we have to send the patient to a nephrologist for further evaluation. So that's regarding my first case. So it's pretty like patient is stable. And after that the biopsy came as membranous nephropathy, and the management was taken care of. Now coming to my next case, it's a female, Mrs. B. She's having a long-standing duration of diabetes, hypertension, dyslipidemia, proliferative retinopathy, peripheral neuropathy, renal failure. So all the complications, macrovascular and microvascular complications of diabetes have taken place. She's having pallor, bilateral pedal edema, and her BP is uncontrolled. And she also has history of recurrent episode of hypoglycemia. And she's on insulin, human mixed start, 30 in the morning and 25 units at night, gliclazide, 80 mg twice daily, metformin, sitagliptin, losartan, 100 mg, amlodipine, atorvastatin, and DAPA. So now, her investigations reveal a hemoglobin of 9 with a creatinine of 2.8. So eGFR is coming around 17 ml with a high normal potassium, low calcium, high phosphorus, HbA1c of 6.1, and urine showing albuminuria. Now, what are the issues? She is in CKD stage 4. She's having severe proteinuria, now fluid overload, uncontrolled hypertension, recurrent hypoglycemia, anemia, and also CKD mineral bone disease changes. Now, how to proceed? First, regarding the management of fluid overload, put her on dietary restrictions, fluid restriction, and salt restriction. So when the fluid and salt part is taken care of, then itself there will be a significant BP reduction, and we can add diuretics. So in case of eGFR less than 30, it's we have to go with loop diuretics, because as we know, thiazide might not be effective. Then control of hypertension, fluid salt balance itself will restore some amount of hypertension control and to escalate the antihypertensives. Now, the next question which comes into our mind is what to do with ARBs. Should we stop RAS inhibitors or should we continue? GFR is already 17 ml. Potassium, it's actually fairly in the range only, though it is in the high normal. Now, what do guidelines say? Do we have to stop or do we have to continue? So as per the KDIGO guidelines, in eGFR less than 30, if we can maintain a close monitoring of serum potassium level, we need not have to withhold the RAS inhibitors. But of course, again, it's an individualized approach. We can continue, but make sure we are getting the patient for regular follow-up. Suppose a patient is coming now and he's coming after 1 year and you are putting on ARBs, then it is like creating unnecessary damage. So basically, if the patient is ready there for regular follow-up, is under your regular follow-up and close monitoring of potassium is possible, then we can continue this, because the antiproteinuric effect as well as the cardiovascular protection effect, we don't have to compromise just because the renal function is has shown a decline. But however, in advanced CKD, if the patient is having severe hyperkalemia, severe uremic symptoms, then we may have to withhold the drug. Now, reduction or discontinuation is based on basically the potassium status, hyperkalemia severity, hypotension level, and also if the patient develops uremic symptoms, it's better to stop. Now, coming to the management of diabetes, target HbA1c, as already told, should be kept in a higher level. See, this 6.5, 7 and all, it's basically for the third stage, CKD stage 3, where still we are aiming control of the complications. A preventive role is there. But once the patient goes to stage 4 and stage 5 CKD, it's always better to prevent hypoglycemia by keeping a target HbA1c up to a level of 8 and all. And regarding sulfonylurea, we have to stop it. Metformin, as the guidelines say, less than 30 ml, we have to stop. And change to linagliptin. See, of the gliptins, linagliptin is relatively safe and we don't need any dose modification, whereas other gliptins need dose modification in renal failure. And regarding insulin, as we know, the half-life of insulin is increased in renal failure. So there is high chance of hypoglycemic events with high dose of insulin, especially the long-acting one. So can change to either analogs or basal bolus. Though no specific insulin regimen has been recommended, there is no recommendation like that. But in practical sense, we have seen decreased hypoglycemia with analogs as well as the short-acting ones. Now, do we need to stop SGLT2 inhibitors? Guidelines say we can still continue till the patient reach dialysis. So initiation, they have kept a target of 20. But again, whether continuation is safe or not should be an individualized approach. We have to closely monitor the volume status because patient might be on diuretics, SGLT2 inhibitors, RAS blockade. So all these things, very individualized approach we have to give. So if the patient is fairly tolerating SGLT2 in spite of falling eGFR or going to an advanced CKD, then we can continue provided a good compliance and good follow-up is there. Now regarding the anemia part, so one thing I have to emphasize in diabetic patients, so we have a diabetic patient with CKD and another CKD patient with another cause. So when we compare diabetic CKD, the CKD due to diabetes, such patients have a relatively higher degree of anemia compared with CKD due to other causes. So in this case, before jumping, so usually when we have an advanced CKD with anemia, this first thing which come to our mind is anemia of CKD and starting erythropoietin and all. But before that, we have to do the iron study. Iron study, as per the recommendation CKD, is to follow with TSAT, transferrin saturation test, and ferritin. A TSAT value of less than 30% and ferritin value of less than 500 nanogram per ml, then we have to supplement with iron. We can give initially a trial of oral iron depending on the severity of the iron deficiency and if there is good compliance and good GI tolerance. And even after 3 months, if the TSAT is very low, for example, less than 15 or 12, then we have to go for IV supplementation. And when we give IV supplementation in CKD patients, it's better to avoid frequent injection. So if you give iron sucrose and such type of iron preparation, we might have to give very frequent repeated administration. So if you resort to ferric carboxymaltose or iron isomaltose with a longer duration of action, where we can stop with 1 or 2 doses, it will be better. And then after restoring iron store, also rule out other causes of anemia like vitamin B12 deficiency, folic acid deficiency, GI bleed. And in spite of correcting all these factors, and if anemia persists, if the hemoglobin is less than 10, then we have to think about erythropoiesis stimulating agents. And after that, in my patient, again, the patient had hypocalcemia, hyperphosphatemia. So there is secondary hyperparathyroidism changes. So we have to maintain the calcium phosphorus balance. We have to supplement with calcium. We have to give phosphate binders. And regarding the usage of calcitriol, rather than in early stages, rather than jumping directly into calcitriol, first monitor calcium and supplement with calcium, and advanced CKD resort to calcitriol. Now, always don't push the calcium into a higher level. Avoid hypercalcemia. And diet and malnutrition must be emphasized. And diabetic CKD patients, when they go for an advanced CKD, there is an increased tendency to go to a malnutrition. They can become malnourished, cachexic. So our dietary restrictions should not push them to malnutrition, and we have to assess the nutrition status regularly. Then regarding the continuation of sodium bicarbonate, so this is helpful in tackling the metabolic acidosis, and this is from the early stage of CKD itself, we have to start supplementing with the bicarbonate. Then regarding vaccination, see, vaccination in CKD, always it is better, especially in case of hepatitis B vaccination, it is better to start in the early stage rather than starting at nearing the verge of dialysis. Because once you start in early stage, the immune response, the immune mounting capacity of the patient will be more in early stages compared to advanced stages of CKD. So hepatitis B vaccination should be given, especially in my patient, it is around 17 ml, that is the EGFR stage 4 CKD. So vaccination should be ensured. And regarding other vaccines in CKD, pneumococcal vaccines, when the EGFR falls below 30, should be given to all. Then annual influenza vaccine. Then the important thing I want to emphasize is the preservation of veins for future AVF. Most of the time in diabetic CKD patients, one of the biggest dilemma we face is getting a good vein for fistula creation. So in early stage itself, when the patient is under the follow-up of physician itself, avoid repeated cannulation, unnecessary injections or venipuncture, so that these veins will be preserved. And when creating fistula, we give importance or a preference to left hand. So basically what we advise is avoid cannulation or injection in the left upper limb, which is the non-dominant arm preferred limb. So preservation of veins for the future AV fistula is very significant. That should be done from the early stages of CKD itself. Then cardiovascular evaluation to rule out coronary artery disease, peripheral arterial disease, erectile dysfunction. Then patient need regular nephrology consultation, especially the patient has gone into a stage 4 CKD. So with these methods or measures, we can fairly ensure a good quality lifestyle for a CKD patients, even they have gone into an advanced stage of renal dysfunction. Thank you.
Excellent presentation.
Yeah, thank you, Dr. Jyotipriya, for giving 2 excellent scenarios where you have a basic minimal changes in the kidney function, and to another patient where you have a end-stage renal disease and management of both the cases. So with that, actually, 2 excellent cases, we go on to our question and answer session, I guess, with Dr. Prashant Shankar. Are we? Dr. Jayamina, are you there?
Yeah, I'm there.
Yeah, yes. So she's given both of you have given an excellent picture. How do you start from the basics of what's happening in kidney in a diabetic patient? to extend, how do you manage both the extreme cases? So do you have any questions from the audience?
I think we have Dr. Balachandran sir, who has joined in. Sir is one of the senior most cardiodiabetology physicians in the state. And sir, welcome to our show, and I request you to
welcome, sir. Welcome, sir. Balendran sir, welcome.
Oh, thank you.
Yeah, thank you for being here.
Very nice of you.
Yeah, thank you, sir.
And there are a few points which I would like to add on the first speaker, Jyoti Meena. What is the name?
Jamina, Dr.
Jamina.
Meena. Okay. What she has done, exemplary talk, right? Exhaustive also.
So you can come on video, sir. You can come on video, sir.
Okay.
Your video.
Yes.
No, not it. Yeah.
Okay.
Yeah, okay.
The talk was very,
yes, sir.
very exhaustive and very good. There are one thing that I want to add is the CKD progression in type 2 diabetes has been divided into 3 categories. One is hemodynamic, another is inflammatory, third is metabolic. So hemodynamic, as we all know, the RAS inhibitors, all those things, they act. And the inflammation and fibrosis, we have some few factors like transforming growth factors and serum amyloid A and VEGF, collagen. All. Then metabolic, of course, we have AGE and NADPH and reactive oxygen species, etc. So these are the things, 3 things in which the treatment is mainly centered in preventing the progression of the CKD patients in diabetes. As far as the hemodynamics are concerned, it is mainly the ACE inhibitors and ARB, dihydropyridine calcium channel blockers, and SGLT2 inhibitors. The metabolic, of course, we have metformin and glucagon like GLP receptor agonists and SGLT2 inhibitors. In the fibrosis part, a lot of things are coming up. Now we have only one particular drug which is called the steroidal and non-steroidal mineralocorticoid receptor antagonist. How does this act, mineralocorticoid receptor antagonist? It blocks the mineralocorticoid overactivation, may slow CKD progression mediated through inflammation and fibrotic pathways. So it is mainly, most of the cardiorenal disease are associated with MR overactivation. So increased gene expression and pro-inflammatory cytokines and pro-fibrotic factors, all those things are being taken care of by mineralocorticoid. Now we have a better drugs like finerenone, of course it was mentioned, and then there are 2 studies like the Figaro and Fidelios diabetic kidney disease trials have been mentioned. And these are all certain newer things are coming up in the inflammatory part of the diabetic progressions. That's one part, one with a comment on the first speaker. The second one is, when I want to comment on the second speaker we have, one is amlodipine. I don't know why Dr. Jyoti Priya did not mention about the hypertension part of it in managing the second case. The amlodipine, usually we don't, because it is not a good drug to reduce the albuminuria. So albuminuria, either you go for the other generations like cilnidipine or ifodipine or benedipine or any other drug to reduce the albuminuria. And amlodipine per se is not a good drug as far as the diabetic kidney disease progression. And of course, amlodipine and nifedipine are supposed to be the excellent hypotensive agents if the person has got an uncontrolled diabetes. But once a person has got an albuminuria, amlodipine is not a good drug to reduce albuminuria. So my comment can be answered. Thank you.
Thank you, Dr. Balajan, for the excellent comments. Anything you want to add, doctors?
There are, I think, 2 questions in the chat box. Prashant?
Yes. No.
Prashant, are you there?
Yeah, right. I think
the first question is, at what stage of CKD do we need to give the double dose of hepatitis B vaccine? Dr. Jyoti Priya?
Actually, this double dose has been recommended for dialysis population. Once the patient has entered into dialysis, then definitely the recommendation is for them to give double dose. But even in the advanced stage, because of the lack of immune bounding, especially in the stage 5 CKD, so we give double dose. So recommendation is for the dialysis population, but even in the advanced stage, we can give the double dose because of their immune mounting response will be very poor. And ideally, after giving the vaccination, 1 month later, we have to follow with the antibody titer, and yearly we have to follow.
The next question, I would put the next question to Dr. Jemina. Is there any advantage for the newer ARVs like Filsartan, Azilsartan, etc., compared with Telmisartan in controlling the albumin?
No, sir. Nothing in specific. No, nothing in specific.
The telmisartan advantages, it has got a PPR gamma receptor agonist action also. It's got a cardiometabolic and a very good cardiodiabetic drug compared to any other sartans.
Can I ask one question to both speakers? You know, I mentioned about the foot ulcers and the role of SGLT2 inhibitor. Like, for the both neuropathic and ischemic ulcers, or only for ischemic ulcers you have to be careful of, or even neuropathic ulcers? What is the exact mechanism, what they say, to limit? Or in the infection with the sepsis? Anyone can.
Volume contraction and probably vascularity compromise.
Vascularity compromise, but that is if you're purely neuropathic ulcers, you have to expect that.
Ischemic probably.
It's mainly for peripheral vascular disease and ischemic ulcer, because already the blood supply will be compromised. And this has been noted, this increased rate of amputation and all in CANVAS trial. But in the subsequent trials, this thing has not been proven. But still, when there is a severe peripheral vascular disease, it's always better to think twice before starting SGLT2 inhibitors.
It's clear. It's more of ischemic disease, ischemic of foot ulcers than the peripheral. Right. Thank you.
If any of the other attendees want to have their comments, yes, Valiot, sir. We can unmute.
A really very interesting and comprehensive session, and congrats to both speakers. So I want to ask one question regarding the first case of the second speaker. And now in that case, was an 8-year diabetic with a creatinine 1 point, and they have started as SGLT. But that patient has got a lot of comorbidity. And why we didn't opt for a insulin in that patient?
Actually, we advised insulin, but the patient was reluctant. So because of their reluctance only, we continued with OHA. But insulin was the first thing we advised.
Yeah, that you had mentioned during presentation.
Yeah.
Yeah, he had already mentioned that.
Okay.
Right. We have another question in the chat box. Can DKD patients have microscopic hematuria in the absence of urological or glomerular causes?
Yes, it can occur actually.
Can I ask one question?
Yeah, sure, Rajesh.
Yeah, my question is, especially in males, we often get confused when we see an abnormal rise of creatine. One thing which happens is the prostatic enlargement, which sometimes can cause a slight elevation in creatine. So, what are the precautions you should take, or how to evaluate the patients, or at what point of time will you consider that the recent rise in creatine could be due to a prostatic enlargement or a post-renal cause? At what point of time, and how would you evaluate for such patients?
Basically, imaging is the thing which helps us. Mere prostatic enlargement without blood pressure changes usually doesn't cause an elevation in creatinine unless the patient is having some prostatic infection, prostatitis per se, with sepsis. Other than that, a mere prostatic enlargement with just a bladder outlet obstruction without a blood pressure changes usually doesn't cause. But always think of prostatitis in such cases, and always rule out a prostatic malignancy in males in case you get a renal failure. There might be underlying hypercalcemia, bone involvement, etc. Always have that in mind while proceeding.
Another most important thing there is actually, even for moderate prostate enlargement, sometimes people can have outflow obstruction sort of thing, or probably reduced flow because of the neurogenic bladder. Maybe severe, like late stage DKD, patients may be also having severe neuropathy and neurogenic bladder also. Their force of, I think probably evacuation will be very low. Bladder contraction, reclusal action will be lower. And that can also reduce probably or create back pressure and have a probably, I think, may add to the renal dysfunction, I think. That is a possibility there. I think so. I don't know. What is a nephrologist's opinion?
Yeah, neurogenic bladder always accompanies this these diabetics along with BPH. That's true. They develop bladder dysfunction even without much prostatic enlargement, and they are actually prone for developing recurrent urinary tract infections, and they actually develop renal failure faster, in fact.
I think one more question to both of you again. This is regarding the recurrent urinary tract infection. I know with the, not recurrent urinary tract. If you get one episode of UTI with SGLT2 inhibitor, would you all stop permanently, or you wait for give a course of antibiotic, wait and restart? And what is the present stand after using for many years, for almost 7-8 years now? So what is the present stand regarding SGLT2 versus being diabetic nephropathy cases with the bladder dysfunction again?
Actually, with one episode of UTI, generally what we do is, in my practice, I withhold the drug. And then after the treatment of the UTI, we'll slowly restart. But if the patient is having recurrent UTI, for example, there is a post-voidal residual urine, neurogenic bladder, all these things, we generally avoid. In just one episode, in my, no, need not. But recurrent UTI and factors like predisposing to recurrent UTI, we generally withhold.
Thank you.
Many of the diabetic patients, they have what is called the sensory paralytic bladder. In fact, they don't know the amount of filling. And many of my type 1 diabetics for more than 40 years, they don't know when to initiate. They go on accumulating at one particular stage, they start initiating and go on passing urine for about few minutes. So this is what happens. So those patients are highly prone to develop probably infections and maybe residual urine. So those cases, you have to be very careful in initiating SGLT2 inhibitors. But another advantage of SGLT2 inhibitors when they combine with ARB is it has got an afferent arteriolar modulation. That the other one has got an efferent arteriolar dilatation. This has got an afferent arteriolar modulation. Both of them will reduce the glomerular filtration state. So they're bound to go up. Creatinine and GFR will come down, and creatinine might go up by 20 to 30%, as suggested by Dr. Veena.
Shant, if there are no more questions, can we?
Yeah, if there are no more questions, I think we can wind up. Suresh sir, Chandri madam has joined, I think, in between. Chandri madam.
Madam, are you there? Chandri madam, are you there? I think she's not there. Anyway, thank you. There are two excellent presentations and from both speakers, very elaborate, and I think probably everyone has been enlightened on diabetic kidney disease and how to go about it and how to manage and when to refer. It's most important when to refer to the nephrologist. It's probably a joint management of diabetic kidney disease and diabetes. It's a very important thing. We have to act as a team. Both nephrologist and the physician treating diabetes has to act as a team. And now I think probably this sort of presentations will be probably helping physicians to manage diabetes better, in a better way. So we'll be meeting next month with such, probably in months to come. I think we'll present similar topic specialist presentations on various other complications of diabetes. And mostly these presentations are going to be on third Thursdays. So make sure all those participants in this meeting to come back on the next third Thursday for Probably next Thursday, September, we will not have thing now. Prashant?
Yeah, yes, sir. We are having
Because
the
that will be our physical meeting. Quarterly physical meeting will be there on September 18th. That's at Kotarakara. So I take this opportunity to invite all the participants in this forum to come to Kotarakara and join us on 18th for a physical meeting on a Sunday morning. And then on virtually we will meet again in October, probably October 3rd Thursday evening, 8 o'clock. With that, thanking both speakers profusely for the excellent presentation, wonderful presentation from both speakers, as well as a very good contribution from Balendran sir towards this. And it is so nice of you, sir, for coming at this late evening and enlightening us on certain very important points. And also I thank both chairpersons for helping us to proceed with these presentations and conduct these proceedings. And I also thank Dr. Prashant for being the event manager at the back end. Thank you, Prashant. Thanks a lot and good night for all. Thank you very much.
Thank you.
Thank you.
Thank you.
I think those general council members, please stay back. We have a brief meeting, some 10 minutes only will take. So all GC members of RSSDI Kerala State, please stay back.